Well, hello, everyone. My name is Gerard Silvestri. I'm a pulmonologist at MUSC. Um, I'd like to welcome everyone in to a review of the Seminal non-small cell lung cancer studies from this year's Multidisciplinary Professional Society meetings. This is our third webinar, and after this, there'll be two podcasts that are related. What's really interesting is that what we decided to do for this webinar is sort of bring the band back together of really exceptional people from around the country in each of the disciplines within thoracic oncology to talk about like what cool things that they see at their meetings, what two or three papers really resonated with them within the specialties of pulmonary medicine, medical oncology, radiation oncology, and surgery. And we'll have each of those speakers speak, and in between, we'll be able to ask them a few questions. Of course, at the end, we'll open this up to questions from the audience. You can put those in the chat, and we'll try to get to as many of those as we can. I'd like to introduce the audience to the audience today, our speakers. We have Miriam Alexander, who's an assistant professor in medicine from the Medical University of South Carolina. Jessica Donington, who is a professor of medicine. We have Adam Fox, who is an assistant professor of medicine and pulmonologist, and Anu Singh, who is a professor of radiation oncology. And with those speakers in mind, I'd like to get started. And we'll go with our first speaker today. And our first speaker, if I can get this advanced, is Adam Fox, who's going to provide us with two of the seminal papers picked this year in the pulmonary space in lung cancer. Adam, welcome.
Hey, thanks for having me on.
Go to the next slide then for you.
The first trial I wanted to review was the Veritas trial. You can see the title page here. This compared navigational bronchoscopy with transthoracic needle biopsy for small lung nodules. This is just a little background slide showing two systematic reviews. So you can see the middle column is TTNA or transthoracic needle aspiration or biopsy. And in the right hand column, we have navigational bronchoscopy. The time periods are slightly different for which these are occurred. Systematic review for transthoracic needle aspiration in 2015 versus 2021 for bronchoscopy. Both included a total of 10,000 or so cases, so a lot of cases that underwent these biopsies. You can see in bold in the middle large row diagnostic accuracy for a transthoracic approach in the 90% range, and then for navigational bronchoscopy in the 70% range. And then you can see complications in the last three rows. So pneumothorax, 20% for transthoracic, and closer to 2% for navigational bronchoscopy. Hemorrhage and other events in the kind of single digits there as well. Full disclosure, Gerard led the effort on this systematic review for navigational bronchoscopy, if you're looking at the references below. But this is sort of the background and setup for this trial is that people really wondered about this diagnostic accuracy of bronchoscopy as technology has evolved to include different imaging modalities mixed with bronchoscopy and different devices to perform those biopsies. Next slide. So the study had several really nice components to its design. It was multi-center. There's 7 U.S. sites that were included. They enrolled consecutive patients who were referred for lung biopsy. They had to be indeterminate kind of size nodule, 1 centimeter to 3 centimeters, with a pretest probability of cancer greater than 10%. For the design, patients were randomized 1-to-1, and it was a non-inferiority trial for bronchoscopy compared to the transthoracic approach. The only exclusions is that it couldn't be a central lung location or have another indication for or indication that it's an advanced disease. So if people had adenopathy, they would have been excluded. Um, and then the result need to be useful. So if they're just going to do SBRT anyway, regardless of the result, then they would have been excluded. And then the real, I think, other than the randomization and consecutive approach, this central review, this last component, a team of people centrally reviewed at the study site eligibility for both procedures. So they had to agree that patients were eligible for both. And that also applied to the pathologic review. So I didn't list it here, but they had pretty strong definitions for diagnostic yield and diagnostic accuracy outlaid from the onset. And they had central review of the pathologic findings that were blinded to what method the biopsy was performed to make a call as to whether it counted as a diagnosis or non-diagnosis. Next slide. So this is just their consort diagram. This screened over 500 patients, and their exclusions were for, I think, good reasons. They didn't meet inclusion exclusion, or patients just declined to participate in the study. And there were 20 people or cases that were excluded due to that central review. So they were felt like, no, this isn't really the right person who's in between. Which way should we go? And of the 258 patients randomized, you can see they had pretty good balance between the two groups. These are just some of the key, the bottom table is just some of the key descriptors. And I think the balance between these cohorts are really important. The average size being about 1.5 centimeters, the location and density were matched. And then those radiographic features at the bottom of the table might make you think that one is better than the other, having a bronchus sign perhaps being better for navigational bronchoscopy, and then maybe a close distance to the pleura being something that might make you more likely to have a transthoracic approach be successful. And they had pretty good balance between these two. And then finally, they had a pretest probability of cancer of about 75%. So these were high risk nodules. They should have been, evaluated with invasive means, and those were also balanced between the two groups. Next slide. These are their outcomes. And at the very top, they chose diagnostic accuracy as their primary outcome. And you can see in that top row, 79% for navigational bronchoscopy and 73% for transthoracic biopsy, with no difference detected between the two, no statistical difference between the two. And then in that secondary outcome row, kind of halfway down, both in the high 70s for diagnostic yield with no difference between the two. The only significant difference that I kept in this table for your review is at the bottom, the number of patients who had intraprocedural rapid onset evaluation, 95% in bronchoscopy, 7% in transthoracic needle biopsy, just a notable difference between the two procedures. Finally, complication rates. Importantly, we had less complications in bronchoscopy. And if you look at the grade 3 and 4 pneumothorax rate, 0.8% versus 11%, I think is noteworthy. When they needed a chest tube, it was similarly about an average of 1 day, and very little other major complications in terms of hemorrhage or respiratory failure or MI. So the author's conclusions were that the diagnostic accuracy of navigational bronchoscopy was non-inferior to transthoracic needle biopsy, and also had fewer complications. And if we look back to the background of the diagnostic accuracy of those systematic reviews, to me, we ended up with a diagnostic accuracy in the 70-ish% range. And that's what Gerard's systematic review would lead us to believe is near the current state now. The interesting thing was that systematic review showing a transthoracic needle biopsy in the 90% range didn't quite bear out in this trial. So to me, that was the finding, the better understanding of these two procedures is the diagnostic accuracy of the transthoracic approach is maybe closer to that 70% range than 90. So that's kind of what I took away from this study. We can move on to the next slide. This was the second trial I wanted to highlight. This is the Watch the Spot trial, and this looked at two strategies for surveillance of small, low-risk nodules. Next slide. So just as the background for this, there's multiple guidelines for and numerous iterations of those guidelines over the years about what to do with a small nodule like the one on the screen. This is one of my patients with a 9-millimeter nodule. And those guidelines evidence are mainly expert opinion and retrospectively based off of data that we have. And so this will be kind of our first randomized and prospective trial, large, and to compare the effectiveness of these two strategies. They had 4 aims. The first aim in the top left-hand corner is lung cancer outcomes. So, for these small nodules, they looked at how many were diagnosed greater than T1, that should be T1B. They looked at time to treatment and survival. These are all 1.5 centimeter nodules or less, so they should all be T1B or less, all stage 1. And then the next 3 aims are patient-reported outcomes like anxiety and satisfaction, resource utilization like scans, biopsies and surgery, visits, and then adherence. So did the physician and patient adhere to the recommendation that was prescribed by the radiologist? Next slide. So for the design, this was a cluster randomized non-inferiority trial. So different sites. You can see we have 14 organizations and 24 sites. The sites were randomized either to an aggressive or less aggressive approach, and so we're comparing these two approaches. Um, this applied to incidental and screen detected nodules. They had different strategies for each. For inclusion and enrollment, radiologists basically enrolled patients by delivering that less or more aggressive strategy. You had to be greater than 35 years old. You had to have a small nodule, 1.5 centimeters or smaller, and it needed to not have specific benign characteristics or specific high risk characteristics they already had metastatic nodal involvement. And then finally, this is just an example of what this low versus high risk strategy may look like. This is on the left in blue, modified Fleischner guidelines from 2005 for incidental nodules. That was sort of the more intensive. And on the right, modified Fleischner guidelines from 2017. This was less intensive. And you can, if you're used to looking at these guidelines, you're used to a range, 3 to 6 months, 6 to 12 months. Well, they eliminated the range and just made it the extreme, either the less or more, depending on which strategy they were making. But more or less, it's just a simplified guideline that they adhered to. This is just the example. They also had one for screen detected nodules. So their results, they enrolled over about 35,000 patients and had about 500 cancers diagnosed in that 2-year period. So 1.5% of their patients were diagnosed with cancer. Mean age about 64, and the average nodal size was pretty small, 5 millimeters. Median size ranging 4 to 7 millimeters. And in the far left, you can see the outcomes that were described in abstract form at ATS this year. Tumor size, tumor stage greater than T1B. Remember, all of these radiographically were T1B or less. And then whether diagnosis was made within 12 months and whether the treatment was delivered within that 12 months or 1 year. And they only had adjusted outcomes in the far right-hand column for the top 2 at stage of diagnosis. And interestingly, about half of patients were diagnosed with a tumor stage greater than T1B, but they don't go into much more detail. Again, abstract form only. So I'm excited to see exactly what those stage distributions look like. But the key is there was no difference in that stage between the less intensive and more intensive groups. So I'm really excited to see their full description of these cancer outcomes, if there really is no difference between these groups in the end in terms of diagnosis and treatment, as well as we've not gotten any of the results from those other 3 aims. The patient-centered outcomes, the resource utilization are particularly interesting to me, and I look forward to seeing those results.
Thank you, Adam. I was going to ask a question in between, but we'll save those for the end. And we'll move along to Jessica Donington, who's going to talk to us about updates in perioperative non-small cell lung cancer. Thank you, Jess, for joining us.
Thanks, Gerard. Always pleasure to be here. I really focused on our last 2 meetings of the year in lung cancer, and those were the World Conference on Lung Cancer, which was in Barcelona. I think from a perioperative space, this wasn't the most exciting meeting we've had in a very long time. We're used to a lot of headlines at every single meeting. But this was a lot of kind of recutting data that we'd already seen and looking a little bit into predictive outcomes within the data sets we have. I was super unimpressed and don't think there was a lot that is clinically going to change what we do for a couple of years to come now. The next meeting I'm going to talk about is ESMO. This was in Berlin just in October. And we did see a little bit more of kind of cutting of the data. We did see nice results with regard to ALK inhibitors. But I think the two really important trials we saw here are highlighted at the bottom. And those are the two we'll talk about. And so let's start with the next slide, which is the 5-year update from Keynote 671. So Keynote 671 is the trial of perioperative pembrolizumab for resectable stage 2 to 3 lung cancer. This was our first positive trial in terms of OS, and now we have our 5-year survival update. And I think this is pretty impressive and pretty important. 5-year OS is still the most important landmark we have in lung cancer survival, and this is a really positive trial. We see an absolute 10% improvement in OS at 5 years with a hazard ratio of 0.74. Let's go to the next slide. The next thing they showed us here are, again, really impressive updates in terms of the event-free survival. So that's, how many patients have recurred, and it's in half, 26 to 49%. That's a lot. Also, I think really impressive in the middle is the forest plots. I don't love forest plots, but when you look there, every single group you look at, even those with PD-L1 less than 1%, saw benefit in terms of EFS in this trial. I think that's important about this is the best we have for this group of patients. The last curve that's there is the super boring one, but that's quality of life. And we're showing here that giving this therapy, because it is a year after surgery, it's the 4 cycles before and a year after, doesn't really seem to impact quality of life, which goes back to baseline pretty quickly after surgery. So is a lot of treatment, but I think really exciting stuff. Next slide. So this result now pairs super nice with what we saw earlier from ASCO on the 5-year update from Checkmate 816. So between the two of them now, we have 2 really positive trials for the use of either neoadjuvant or peri-adjuvant immunotherapy for resectable stage 2 to 3. The benefit here, again, is regardless of PD-L1. So the PD-L1 zeros are included here. I think this is quite different from what we see from the strongest of our adjuvant trials in this space, which was Empower 010. While we do see benefit for those who have high PD-L1 expression, for all comers, this was not a positive trial. So again, my enthusiasm for upfront treatment for that population. Now, the next really exciting trial was this MDT Bridge trial, and we follow the first efficacy report at ESMO. So this is a kind of different trial. It is looking for the rate of resectability and to see if we can take unresectable patients and make them resectable by giving them immunotherapy. Are these dramatic responses that we see able to do that? It's a very big change for surgeons. We were all taught in surgery school that you have to determine resectability up front, and this really challenges that. So patients who are resectable or borderline resectable got 2 cycles of chemoimmunotherapy, were then brought back to the multidisciplinary team for reevaluation, and big reevaluation, PFTs, PET, the whole 9 yards. And then from there determined if they were resectable, they got 2 more cycles and went to surgery. If they were unresectable, they then kind of moved over to more of a Pacific regimen. They got chemo radiotherapy followed by durvalumab. And the primary endpoint on this trial is actually resectability and how many patients make it to surgery. Next slide. So this is the really cool plot that we don't know the name of. But it basically looks at the first 84 patients, 56 of which were thought to be resectable, and the overwhelming majority of those patients went to surgery, like 90-some%. But even in this borderline resectable group, this group who probably should not be resectable, 23 of those went on to surgery. So that resection rate is really quite high. Also, equally important in my view is that of those patients, the 12 who became unresectable or stayed unresectable, 8 of them went on to concurrent chemo rats. They got the best treatment they could get, and this aggressive, inflow didn't affect that, and I think that's really important. So I think this trial is a real change in mindset for surgeons. Next slide. These are the resectability rates. So overall resectability, 85%, as good as our previous trials. And in those who were felt to be resectable, 92. As surgeons, we're getting better at this, determining who can handle this treatment and who can't. But even in that high risk group, 71% went to surgery. The R0 resection rates were excellent. We're not doing patients a disservice. Next slide. And then finally, the fact that you can we always say that we don't know if the responses we see on CT really go along with what we see in the OR. This is giving us the indication that maybe we are. Maybe that interim visit, when we see a little bit of a response on the CT, is showing us that these patients are going in the right direction. Because if we don't see that response, chances are that it's not. So I thought this was a really important trial, and the real takeaway here is the fact that we might be able to use these dramatic responses to make more patients resection candidates. And with a 65% survival for that approach, I think that's something worth fighting for. Next slide. So my takeaways here, we now have 2 trials with 5-year overall survival improvement for both neoadjuvant or periadjuvant chemoimmunotherapy. 65% overall survival, really impressive in a dominated stage 3 population. I think this really pushes a lot of the stage 3 patients back into the surgery first arm if we can do it, which really makes us have to think about what's a resectable patient, both from a surgical standpoint and a medical standpoint. And again, maybe adding in the chance of a dramatic response into how we think about these patients at our tumor boards.
Thank you so much. That was awesome. By the way, it came to me as you were saying it. It's a Sankey plot.
A Sankey plot. Thank you.
Yes. I'm going to turn over now to Ani Singh from Roswell Park Cancer Center, a radiation oncologist, for him to update us with our lung cancer research and radiation oncology. Anu?
Thanks very much. I'd like to present data from this year's Astro and ASCO, but we're going to give some background first. The study that I want to talk about deals with surgery versus SBRT, also known as stereotactic body radiation therapy, and in some countries called stereotactic ablative body radiation, or SABR, which sounds cooler. And this is data from 2 studies that tried to randomize patients to surgery or SABR, and those studies were called STARS and ROSELLE. Neither study completed accrual because, as you can understand, it's hard to randomize patients to yes/no surgery. But what the study showed is that SABR performed well and was not statistically significantly worse than surgery, and perhaps it was even better. But you have to keep in mind that this is a retrospective review of incomplete prospective trials. Next slide. There was updated survival from another trial called the Revised Stars trial. And in this case, what you're comparing is a prospective 80-patient SBRT cohort with a relatively small N0 lung cancer, and a matched surgery cohort that was also prospective. So this is not a randomized study. It's matching 2 prospective cohorts. And what you can see is that at 7 years and 10 years, overall survival and lung cancer specific survival is overlapping. Next slide. Now, recurrence-free survival, there were some differences. Specifically, there tended to be more regional-only recurrences in the SABR group, but it didn't affect overall survival. Next slide. And they also had quality of life data. And while they noted that acute toxicity was worse in the patients who underwent surgery, over longer term follow up, there was no real difference in the quality of life for those who underwent surgery or radiation. Next slide. So the author's take-home points is that at 10 years, SABR is not inferior to video-assisted thoracoscopic surgery, lobectomy, and with mediastinal lymph node dissection. Overall survival, lung cancer-specific survival, and recurrence-free survival were the same. There was higher acute toxicity, but quality of life and financial stress in both cohorts was not significantly different after 10 years. Next slide. So these are the current surgery versus SBRT trials. The one that's furthest along is at the bottom. That's the VA trial, also known as Valor. And hopefully we will get data from them relatively soon. Next slide. So Dr. Donington talked about several studies that looked at neoadjuvant and periadjuvant immunotherapy with surgery. We wanted to know in several studies whether radiation could have similar benefits. And so here, SBRT was done in 3 to 8 fractions, and in one group, atezolizumab was given before, during, and after SBRT, and in the other group, it was SBRT alone. And what we found, next slide, in data presented at ASCO, was that atezolizumab did not benefit either overall survival or progression-free survival. Next slide. In addition, unlike what Dr. Donington presented, where placebo versus pembrolizumab did not affect the toxicity, in this instance, there was significantly greater toxicity in the atezolizumab arm. Next slide. So there's other data, including Keynote 867, where a similar patient population was enrolled. Patients were randomized between SBRT and adjuvant pembrolizumab versus SBRT and placebo. Again, that study closed early following an interim analysis because pembrolizumab did not improve either event-free survival or overall survival and did increase toxicity. Next slide. There is one study that's remaining in the field, and that is Pacific 4, which is randomizing patients to SBRT plus durvalumab or SBRT with osimertinib, and this study has yet to report.
I'm going to move now to Miriam Alexander, our medical oncologist, who's going to review some studies for us from the oncology field. Thank you, Miriam.
Thanks, Gerard, for having me. So I feel like we did have some exciting updates in both World Lung and in ESMO for metastatic lung cancer. So just want to remind everybody that non-small cell lung cancer has evolved considerably over the last decade. We cannot think of it just like adenocarcinoma or squamous anymore. We have so many different molecular alterations, next slide, for which there are a lot of therapies that are approved. As you can see here, and just a plug for molecular testing in general, that we won't be able to offer any of these therapies if we don't have tissue to test with next generation sequencing. So plea to our pulmonologists. Next slide. So in World Lung this year, we saw some updates for EGFR mutant lung cancer. So as a background, these are caused by mutations in the epidermal growth factor receptor, or EGFR. We were offering the third generation tyrosine kinase inhibitor osimertinib, and that was based on this FLORA trial where osimertinib was compared to the first generation EGFR inhibitors. And there was significant benefit in both PFS and OS, and also improved intracranial penetrance with this therapy. And this was our standard of care for several years. So on the next slide, you'll see that over the last 2 years, our frontline has advanced, and we now most recently have the overall survival results of the pivotal FLORA-2 trial, where chemotherapy was added to osimertinib, and this regimen was compared to osimertinib alone. So we saw during this meeting that the overall survival was 47.5 months compared to 37.6 months with OC alone. So pretty significant benefit, with all subgroups benefiting, including those with CNS metastases, making this one of the new standards of care. There were understandably more chemotherapy-associated toxicities with this combination. On the next slide, we can see that we also had updates on the frontline trial looking at amivantamab. So just to orient everybody, amivantamab is a bispecific inhibitor that blocks both EGFR and another tyrosine kinase called MET. And upregulation of MET usually commonly acts as a resistance mechanism for EGFR. So when amivantamab was combined with lazertinib, so lazertinib is another third-generation EGFR inhibitor like osimertinib, and then that combination was compared to osimertinib. The overall survival data, survival for so far is not reached in the combination arm, and 36.7 months with OC alone. So the benefit overall is looking close to a year. So pretty significant too, very similar to the FLORA-2 survival. So this regimen has kind of different toxicities, more rash and dermatitis and some thromboembolism. So our discussion with our patients have gotten a lot more complicated for frontline EGFR, but we really want the survival data really makes us want to make sure our patients have a chance to be on one of these two regimens, especially if they're young, have less comorbidities, want aggressive treatment, and have some high-risk features. Next slide. We also got an update for one of a more rare type of alteration called ROS1 rearrangement. So over the years, we've had multiple tyrosine kinase inhibitors. If we look at the left side of the slide, that showed benefit in this population. Example is crizotinib. These are not as specific for ROS1, so they're more multi-kinase inhibitors. So this figure on the left side was highlighting the efficacy and response rate with several agents. So what was happening over the years is development of more optimized ROS1 inhibitors that are more specific to ROS1 and not multi-kinase. So our leading agent over the last few years was repotrectinib, but we recently had approval of this drug called taletrectinib. And then in Lung, we had a presentation of the ARROS-1 clinical trial, which presented this other drug called zidesamtinib. The response rate is 89%, and more importantly, intracranial response rate of 83%, including 67% complete response in brain. So I'm excited about this agent because what you can see on the bottom right there is that even patients who've had prior ROS1 agents, even really important agents like repotrectinib and taletrectinib, they had response to this drug zidesamtinib up to 43 to 47%, which means that this drug can overcome some resistance mechanisms. So I anticipate we will have access to this therapy soon. So even though this is a rare mutation, if a patient is currently treated with this agent or these agents, it will be life-changing for them. I'll give an example of a patient who had come into my clinic with very significant ascites and pleural effusion and was actually recommended for hospice from inpatient setting. We were able to get the ROS1 testing with circulating tumor DNA in less than 7 days, in about 6 business days, and he started him on taletrectinib, and he's actually going back to work now, and it's just a few weeks. No further effusions. So I know it's rare, but very, very important, life-changing for this patient. And as long as he continues to respond, and if he progresses, depending on his resistance mutations, I will hopefully have this other agent, available at that point. The next slide, we saw some updates on HER2 mutated lung cancer, another rare mutation, but a little bit more common than ROS1. Now, the exon 20 insertion mutation in HER2 is the most common of these. And so far, frontline is still giving chemo and immunotherapy. We're not getting as much long-term control of their disease. So we are looking for better agents. We have approval of an antibody drug conjugate called TDXD, that's on the bottom left, or Enhertu. That works for these patients. Its response rate is about 56% in the second line setting. But on the right side, what I want to highlight is two tyrosine kinase inhibitors, or two small molecules. One is called zongertinib and one is called sevabertinib, which is now approved already in the space just very recently over the last few months. So zongertinib in treatment-naive patients, response rate of 77% and 71% in those that got chemo first. And for sevabertinib, response rate of 71% in the front line and 64% in those that had chemo before. So one thing to highlight here is that both these agents are small molecules with good brain penetrance. So that significantly changes the prognosis for these patients to have their CNS metastasis controlled. And lastly, I just want to provide an update on small cell lung cancer. Just want to make sure you guys saw the updated data for tarlatamab. So just a reminder to everybody that our frontline treatment for small cell has been chemo and immunotherapy. Average overall response rate, average overall survival about 13 months. We also, haven't shown this, but we recently had an approval of adding an additional chemo agent called lurbinectedin, which added another 3 months. So our average frontline survival, overall survival, is about 16 months. So on the next slide, I just want to highlight that we have a novel agent, a bispecific T-cell engager called tarlatamab. It's currently approved in the second-line setting for patients with small cell lung cancer and is changing the game for small cell. And then the data from single-arm Delphi 303 trial, where they added tarlatamab to maintenance immunotherapy in the frontline setting. Just want to highlight that overall survival months is 25.3 months. Quite remarkable for small cell lung cancer. Really will change the landscape if it's confirmed in the phase 3 data, which has now finished enrolling, and we should have data hopefully sometime in the next year. And I think we'll change our frontline. So few highlights, but very exciting developments for metastatic lung cancer. Thank you so much.
Thank you. I think I'm gonna, and here are the references. I'm gonna stop sharing my screen in a second. Here are some of the references, and here are more of the references for these wonderful articles. First, I want to really thank my speakers. And what I'd like to do, I'll stop sharing my screen. I want to start with some questions, and we'll look into the chat box in a minute. But I want to start with you, Miriam. You talk about these rare mutations, right? But I was looking at that pie chart, and I want you to sort of emphasize to the pulmonary community that you start adding these small proportions of patients up, and they add up, right? 3% for HER2, this much for ALK, this much for EGFR, which is much more common. But you have to be tested, right? And so I've often thought a rising tide lifts all boats. None of those drugs can be given unless they're tested for, right? And the only way to test those is through NGS testing and histopathology, et cetera. And so I want to sort of get an idea from you about how frustrating it is when you start to see these patients who come to your clinic, not necessarily from one of the pulmonologists on our staff, but from outside, that don't have their testing done or even attempted yet.
Yeah, no, that is frustrating because you start having a discussion about chemo and immunotherapy, which is our standard of care, and then if we can get testing at some point, and then suddenly they have an amazing targeted agent, they haven't had the opportunity to get it. I have unfortunately seen patients who've been referred to us where insufficient testing was done, or they mainly didn't have tissue or didn't send it, or they were reassured with circulating tumor DNA, which can be false negative, right? Because it depends on, how much is shed into the blood. And so, and then they were told there was no targetable alteration, but then we got more tissue and tested and found a targeted agent for them. So it just to our pulmonologists, as much as we want to do all the ctDNA, it's more complementary and we still want tissue. Some of these agents are approved based on immunohistochemistry, which can only be tested on tissue. So they're very important for us to have more tissue.
And I know that Adam would support that. And, for us, for the people listening in the audience, doing, 6 or 7 passes per lymph node, making sure we conserve tissue, talking to our oncologists and pathologists about how they want that tissue sent to them, particularly pathology, and getting the orders written up front, so reflex testing to get those done. So thank you for that. I'm going to jump to Adam and ask a quick question, or ask him to comment on something that I think is really important from the Veritas trial, which is, I think, one of the messages that got to pulmonologists. Well, since the diagnostic yield was the same and the side effects were lower, shouldn't we just have patients undergo all patients undergo a bronchoscopy at first? But like hidden in that, and you discussed it a little bit, was the fact that both had to be eligible for either procedure. And I'd like you to sort of take us through, well, what if they're not? Give me a scenario where you might say as a clinician, hey, no, like, this would be better for needle biopsy or better for bronchoscopy. Could you take us through that, please?
Course. I think it's a really difficult question to start off. What I would say is that we need to make sure that our decisions are made based off of the risk of malignancy or the need for tissue. And so at some point, it isn't how small can you biopsy, it's also should you biopsy it. And then you have to look at your local expertise and technology. Not all navigational platforms are probably the same as well. And I think it really highlights the multidisciplinary nature of lung nodule management. There are certainly locations that, even with the newest imaging modalities, intra-procedure and things, that it may just be simpler for a transthoracic approach. Bifissures are particularly troublesome. Depending on the location of any emphysematous blebs or other things like that, that can certainly predispose one or the other to be disadvantaged, just depending on it. Um, and so I think that as you get smaller and in certain locations, it does make sense to not have a one size fits all approach. And sometimes it's a discussion with our counterparts in interventional radiology. Hey, this looks like a pretty difficult case for me. What do you think? It's not as easy as just distance to pleura. There's other structures, vessels, and things that might be in their way for a biopsy. Um, yeah, I think the more central you are, the larger size certainly would help us to be more central for the navigational bronchoscopy side. Um, but yeah, I think there's definitely a place for selection bias to still play a role. They were able to eliminate that in the trial, and we need to try to eliminate that in our practice to some degree.
That's great. I mean, I've argued, sort of three things should go into this. Technique, how good is your technique? And I think we need to be honest, keep our own data and see how good we are at getting a diagnosis in these nodules. Technology, how good is the technology? And right now, the sexy kid on the block is robotics. And is it really as good as people are saying? It may well be, but we'll see. And the Reliant trial looked at EMN versus robotics. And then patient selection, and you talked a little bit about that. Selecting the right patient for the right procedure is the third leg to that stool, and I think that they really need to be thoughtful about all those. We see people posting online things like, "I got a half a centimeter ground glass nodule with navigational bronchoscopy, touching the pleura." And my response is, why did you even go after that? That maybe should have just been observed, right? So I'll open it up now for any questions to Miriam and Miriam and Adam from our other two speakers, Jessica and Anu.
Can I ask a question?
Yes.
So, robotic bronchoscopy, the platforms, how much of this, what's the learning curve on this? Like your technology and your procedures are getting more and more technical. And yet I still see lots of groups where the people do these once a month, once every 2 months. Is that a realistic model, or is this like any technical procedure really need reps?
That's a great question. I think it would depend on the person performing the procedure and who they're selecting for the procedure. I think there are some lesions that you would choose to use this platform for that are fairly straightforward, and if it's a part of your practice, it's pretty reasonable. And then I think, like Gerard kind of hearkened to, there's these people that this is all they do are these biopsies, and they can have very pretty pictures and case reports of astonishingly precise biopsies. Um, so I do think that there's a spectrum, and I think, like Gerard said, we have to be careful about who we're selecting and who maybe your personal expertise for the procedure. But so there is a learning curve, absolutely, and I think that it is a little bit more because there's so many possible add-ons for intra-procedural imaging with ultrasound and different ultrasounds and CT and things that are sort of like CT or just fluoroscopy. And I think it does depend on who you're selecting. So I think if it's uh, has enough positive characteristics that if it's even something that you do not too infrequently, that it might still be reasonable. But there's definitely cases that only maybe certain people with certain expertise should be going after.
Yeah, I would echo that. I'd also say, look, we have a new field, a relatively new field, over the last 2 decades called interventional pulmonologists, and these are real experts who do high volumes of cases. And so it's that the age-old question, Jessica, should you regionalize your care to a center that has high volume, right? And so surgeons have actually been able to show that uniformly in almost every surgical procedure that higher volume usually is better outcomes. And it's not just the surgeon, right? It's their support network in that institution, right? It's high quality pathology, it's ICU care, it's the ability to have a multidisciplinary tumor board. So it's a controversy that continues to exist. I would say I'm kind of a little bit down the road on this. And if you have access within 5 or 10 miles or 20 miles, or you're in a major city, you have an excellent interventional pulmonary group doing that, you should probably refer them, right? Like you shouldn't, you should get the patient to the right care. Who would you send your mother or father to, right? On the other hand, I do think that some communities don't have that access, and they also have an excellent physician. So denying that person a high quality procedure is probably not fair either. However, everyone should be a master of their own technique. And I don't think doing any case once a month or less than 10 times a year will provide a high quality care, whether that be endobronchial ultrasound with fine needle aspiration, for which I think the more you do, the better you get at it. So I'd leave it there. I think that controversy is going to go on forever, right? But I, as a general rule, if you're close to a center that does a great deal of these procedures, probably refer to a regional center with high quality interventional pulmonologists who do that all day is probably a better way to go. Adam, I'm going to really quickly turn to a question on the Watch the Spot trial, of which MUSC was a site for that trial, and just sort of share with you that is paper is on the review. But one thing I'd like to share in Michael Gould's outstanding work on this is that in either group the adherence was very low, right? And one of the things one of the most important things that may come out of that trial is it doesn't matter whether you have a careful follow-up or a close follow-up versus a further out follow-up. If you don't follow them up, it's a problem, right? Like, and that's the critical issue among our pulmonary community. And by the way, these very small nodules, every nodule has to start somewhere. And so one of the things we've done in the screening community is to say, look, if it's less than 5 millimeters, we're not going to follow it. But I think what people need to understand is that small nodules ignored some of those, not many, are going to become bigger nodules, and they are cancer, and they could get out of our sort of realm of being at the early stage tumor. And time to diagnosis, I think, is going to become a really increasingly important part of what we do as pulmonologists and as surgeons, because at some point we're going to get better data. We're already starting to see some that say, look, if you wait 6 months, if you wait even 4 months from the time of diagnosis to surgical resection, you may be changing the level of what the stage of that person is. So, Adam, and I'd also ask the rest of my colleagues to ask the next any questions for Jess Donington, Miriam, or Anu.
Jess, what do you think overall? We're seeing patients who maybe second opinions and things like that who got in neoadjuvant chemo immuno and they end up not being surgical candidates. Do you feel like that MDT bridge is almost reinforcing people to because to do that without consulting surgery? I'm just like wondering if that's going to be
That is my fear, is it's gonna tell people that they can take on that approach for everybody, and I think, we recently saw a review out of Penn saying, "Oh my goodness, only 60% of our induction, chemoimmunotherapy patients make it to surgery," but I think a lot of those patients weren't seen by a surgeon up front. So I do think that if the expectation is you want them to go to surgery, they need to see a surgeon up front, and because there's a lot of things that make someone unresectable, and that's not that depends not only on the surgeon, but the institution, the tumor, the patient. It's just such a multifactorial thing. I do think one of the most important things that's going to come out of MDT Bridge, and this is what the new wave of radiation trials look like too, is that it's okay to give those 2 cycles up front and then move to Pacific. While we haven't seen benefit in giving immunotherapy during radiation, before might be the next place we can add some, and that's kind of the next wave of trials, and watching those patients, I always say on the off ramp, at that pivot point, still being able to go and complete Pacific is as important a message as anything else there, that we
Anna,
can do that.
Anna, could you add in what
Yeah, so
I know that radiation oncologists have been very concerned about trying to add radiation after immunotherapy, and so tell me what you think.
yeah, so I mean, I think that's an open question, and the preliminary data suggests that there will be suboptimal outcomes with that approach. Now, Dr. Donington is absolutely right that that specific question hasn't been asked, where you're just doing the neoadjuvant and then swinging in. I do think that it is appropriate if the vast majority of patients are able to go to surgery, right? To sort of salvage the small number who can't, right? My concern is that whenever you're talking about regional centers, right, or super centers where they're doing a lot of cases and they have a lot of experience, that's not always the way things work as these processes come out into the community, right? And that is ultimately my concern. So if Dr. Donington is amazed with what happened at Penn, right? One can only imagine, what happens when you get to a community hospital, right? Or a larger regional center, right? And where maybe lung cancer isn't what that surgeon does all the time, right? There's still some more general surgery going on. So I have a lot of concerns about that. I also, going to Dr. Alexander's slides, right? When she keeps giving me 5 new approved drugs for different, different things that occur in for patients who are left-handed and below the Mason-Dixon line, right? I really start to wonder, how much of my brain needs to be devoted to these new drugs that are now FDA approved, or and how does someone whose job it is to do this all the time, keep up with that? But along the same lines that we were talking about, well, what happens when you go to a community center, right? And you're not just doing thoracic all the time, right? When you're more of a general medical oncologist, how do you keep up with these things? And Dr. Alexander, if you could help me out, I'd greatly appreciate it.
I think it just I'll put my cell phone in the chat. So just phone a friend.
Well, that's not no, listen, that's not we laugh at those things, but the reality is that Miriam is an expert in lung cancer, but she's also there for the rest of our state. And so I do think medical oncologists understand that and reach out and present these cases at a multidisciplinary clinic. So we have a virtual tumor board where people can present those, and they do have our cell phone and say, "Hey, what do you got in case my patient's not doing well?" I'm sure people reach out to all the people on this call for their expertise. I do think it's impossible to keep up. And at one point, I wanted pulmonologists to know about some of these mutational markers. Now I've like simplified it and said, "Hey, just get enough tissue. We'll take care of the rest," right? Like pathology will tell us which markers we have, and then oncology will treat those markers. So for pulmonologists, get us enough tissue, get it quickly to the pathologist, get the testing ordered. So I do think that that's kind of the way to go. I agree with you. But I would also say again, you get one of these alterations and the right drug, it's hitting the home run ball, right? Like for that patient, we all have patients now. I've been doing this 30 years, probably longer than anyone on this call. At the beginning of my career, no one with stage 4 disease lasted more than a year. Now I have patients out 5 years. Miriam and I share a friend of mine who's out 5 years, never smoker with lung cancer, who's out 5 years and still working every day. We never saw that from metastatic patients. He hit the home run ball by having an EGFR mutation and going through osimertinib and other like drugs. So I think it's the onus is on us. There was a question, by the way, that came through the question and answer from Lucia Viola, a very lovely name. She's asking, are there any more specific protocols out there? And I'll ask either Miriam or Jessica to answer that question.
Um, there were like 12 Pacific trials at least. The ones that didn't come positive, none of them have come positive except for Pacific. Um, and I mean, Pacific Brazil was actually fairly positive. I think we're going to continue to see that. That's become, our staple approach is what do we add to that? So I think there will be more coming through.
Miriam, are you familiar with any of those?
No, I actually am not as familiar with. I mean the one Anu presented. Some familiarity, but I don't know all of the other ones that are coming out.
Right. I do have a little bit of a radiation hat. I'm the surgical chair for the NRG.
Oh, there you go. So yeah.
So I sit quietly and say, yeah, don't operate on with radiation anymore. But I do get to hear kind of what's coming down the pipeline and which have come negative. And yeah, it's actually a little bit unique to lung cancer that you really cannot radiate during the radiate. You cannot give immunotherapy during the radiation. It just seems to just not work at all. We probably radiate way too many of the T cells that might be really unique to lung cancer, and those are really all gone away. It shouldn't be the same for targeted agents, but we don't know. Again, we have to really test. Um, but again, I think the next set of trials is moving more of the targeted agents and the immunotherapies to the front line, to the first step in locally advanced chemoradiation. I think that makes sense.
So the question, Lucia is back on, and we're gonna have to answer this very quickly. She met the MDT bridge and all the neoadjuvant stuff. Is there any space for Pacific?
Oh my God. Let's keep
Oh.
in mind that 3/4 to 5/6 of all stage 3 patients are treated with chemoradiotherapy. Surgery is this very small group there. I would say the overwhelming majority of stage 3 patients are still, are either unresectable due to extent of disease or comorbidity. Surgery is just kind of finding its way in there. I think there was a time that by definition, N2 disease was unresectable, and that might be changing, that now we take a little closer eye, and so I do think there's a chunk of patients who will come to surgery, but oh, no, 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 no. Pacific is still king, don't kid yourself.
All right, and with that, I want to thank this outstanding panel for always teaching me something, and I hope our audience something. Thank you, Adam. Thank you, Miriam. Thank you, Anu, and thank you, Jess. Also, like to thank the folks at Cheston and also AstraZeneca for supporting this program. And with that, I'll let you go. Be on the lookout for 2 podcasts where I ask our panelists in short form what they thought of the studies we reviewed today. So thank you very much, and we'll end here.
Okay.